Pituitary adenoma, hormonal and medical management. Classification of pituitary adenomas according to endocrine function. Adenomas with GH-excess, PRL-excess, ACT-excess, TSH-excess, FSH/LH-excess. Plurihormonal adenomas. Adenomas with no apparent hormonal function. Cushing's syndrome versus Cushing's disease. Cushing's syndrome is a syndrome due to excess cortisol from pituitary, adrenal or other sources, exogenous glucocorticoids, ectopic ACT, etc. Cushing's disease is hypercortisolism due to excess pituitary secretion of ACT, about 70% of cases of endogenous Cushing's syndrome. Evaluation of suspected Cushing's syndrome. History: increased weight, growth retardation in children, weakness, easy bruising, stretch marks, poor wound healing, fractures, change in libido, impotence, irregular menses, mood changes. Exam fat distribution, hypertension, proximal muscle weakness, thin skin and ecchymosis, purple striae, hirsutism, acne, facial plethora, edema. Corticotroph adenomas. Laboratory evaluation. Establishing hypercortisolism. Distinguishing ACT-dependent from ACT-independent causes of hypercortisolism. Differentiating Cushing's disease from ectopic states of ACT excess. Establishing hypercortisolism. Urinary free cortisol. Sensitivity 45 to 71%, 100% specificity. Overnight dexamethasone suppression test. All low-dose dexamethasone suppression test, little test. 0.5 mg 48 hours. Cutoff for serum cortisol less than 1.8 micrograms/dl, less than or equal to 15 mol/L. Sensitivity 95% and specificity 88%. Cushing's syndrome usually have levels greater than 275 mol/L, 10 grams/dl. Nocturnal salivary cortisol. Nocturnal salivary cortisol. 93% sensitivity, 100% specificity. Levels less than 4.0 mol/L, the diagnosis of significant Cushing's syndrome is unlikely. 7 to 8 mol/L are abnormal. Establishing ACT dependency. Measurement of plasma ACT levels. ACT level less than 1.1 mol/L, 5 pg per milliliter, by ERMA is consistent with an ACT independence. Corticotroph adenoma, moderate elevation. Ectopic ACT-producing lesion, marked elevation. Differentiating Cushing's disease from ectopic states of ACT excess. High-dose dexamethasone suppression test, 2 mg for 48 hours, and measurement of urinary cortisol/17-hydroxycorticosteroid. Overnight 8 mg dexa morning serum cortisol. CRH stimulation test. Meteropone test, inhibitor of 11-beta-hydroxylase, inferior petrosal sinus sampling. Classical clinical and biochemical CD features with MRI-negative patient equivocal suppression and stimulation test. Diagnostic accuracy is 80 to 100%. Blood samples are obtained at basal and 3,5, 10 minutes after CRH administration and IPS/PS ratio calculated. IPS/PS greater than 3 CD. IPS/PS less than 2 ectopic. Rarely 2 to 3 ectopic. IPS gradient helps in lateralization of adenoma. Cushing's disease indications for medical management. Failure of all other treatment modalities. Preparation for surgery to relieve extreme symptoms. Interval between RT and development of eucortisolemia. Drugs. Ketoconazole. Aminoglutamide. Meteropone. Mitotane. Etomidate. Mifepristone. Octreotide, ketoconazole, first-line drug. 17-alpha-hydroxylase, 11-beta-hydroxylase, 18-hydroxylase, and especially 17,20-lase enzymes are all blocked by ketoconazole. 400 to 1,200 mg/d, average 800 mg/d. Effective in 70 to 100%. Liver toxicity 15%. Aminoglutamide. Inhibits the first step in cortisol biosynthesis, cholesterol pregnenolone. Effective 50%. 250 to 2000 mg/day. Can be given with ketoconazole. Meteropone selective inhibitor of 11-beta hydroxylase effective in 85%. Doses of 750 to 2000 mg/d. Acne, hirsutism, mitotaine. Adrenocorticolytic effects and direct inhibition of steroid synthesis. 2 to 4 grams/day. Effective in 80%, long-term remission in 30%. High response rate with concomitant pituitary irradiation. Contraindicated in women planning for pregnancy within 5 years. Side effects: gastrointestinal, hypercholesterolemia, adrenal insufficiency, etomidate life-threatening situations with severe hypercortisolism. Oral dosing is contraindicated. Dose of 0.1 mg/kg/h. Eucortisolism achieved within 11 to 48 hours by using a continuous infusion. Mifepristone. Major vegetative depression, suicidal ideation with hypercortisolism. Octreotide. Ectopic act source. Prolactin function: serum prolactin levels, normal 5 to 20 nanograms, ml. Dynamic tests. Not used if prolactin levels greater than 150 nanograms, ml or tumor is found on MRI, CT. Used if prolactin levels are mildly elevated and MRI findings are equivocal. Stimulation tests. TRH. Chlorpromazine. Metoclopramide. Suppression tests. L-DOPA. Nomifensin, prolactin less than 25 nanograms/ml, normal 25 to 150 nanograms/ml. Prolactinoma. Stalk effect. Drugs. Hypothyroid. Greater than 150 nanograms/ml, prolactinoma. Hook effect. Even large elevations will show normal PRL levels on testing due to large size of molecules. Do serial dilutions. Elevated prolactin levels physiological dash. Pregnancy. Lactation. Pharmacological dash. Psychotropic drugs. Antihypertensives. High-dose estrogens. Pathological dash. Hypothyroidism. Chronic renal failure. Hepatic diseases. Cushing's disease. Prolactinomas indications for bromocriptine therapy. Non-invasive prolactinoma and serum prolactin level 150 to 500 nanograms/ml. Serum prolactin level greater than 1000 nanograms/ml. Residual, recurrent prolactinoma following surgery. Criteria for cure. Normal prolactin level. Asymptomatic. Negative MRI study for 5 years. If prolactin level is less than 100 nanograms/ml and shows no tendency to rise, is indicative of stalk damage. Prolactinomas. Only pituitary tumor for which medical therapy has a proven primary role. Observation. Dopamine agonist. Bromocriptine. Catecholine. Dopamine agonist. Selective activation of D2 receptors located on lactotroph cell surface. Decrease adenylate cyclase activity. Decrease in cAMP level. Inhibition of PRL synthesis and release. Dopamine agonists. Bromocriptine. Catecholine. Pergolide malate. Gyride. Quinaglide. Side effects: GI intolerance, postural hypotension, constipation, nasal stuffiness. Bromocriptine, 2-bromo-alpha-ergocriptine malate. Developed by Flukiger and colleagues in the late 1960s. Purpose was inhibiting prolactin secretion without the uterotonic, vasospastic properties of other ergots. Serum levels peak after 3 hours, and the nadir is observed at 7 hours with very little bromocriptine detectable in the circulation after 11 to 14 hours. The absorption rate from the GI tract is 25 to 30%. Very high first pass effect. with 93.6% of a dose being metabolized and only 6.5% of an absorbed dose reaching the systemic circulation unchanged. Excreted via the biliary route into the feces. Levels in the fetus about 1/4 of that found in maternal blood. Start low dose at 1.25 2.5 mg day at night before increasing to 2.5 to 10 mg per day in divided doses. Take with food to reduce side effects. Cabergoline. Titrate these based on prolactin levels and tolerability. More effective. Less side effects than bromocriptine. More expensive. Given once or twice a week with a starting dose of 0.25 mg 2x week. Titrate these based on prolactin levels and tolerability. Acromegaly somatomedin C, IGF-1, always elevated in acromegaly. GH levels fasting state and after administration of stimulatory or inhibitory agents. Stimulatory tests. Insulin-induced hypoglycemia after 4 administration of 0.1 to 0.15 U/kg of plain insulin. GH level greater than 5 nanograms ml indicates normal function. It is avoided in elderly, those with cerebrovascular disorders or convulsive disorder. Oral glucose suppression test. Failure of suppression of elevated levels of GH to less than 2 nanograms ml after 75 grams glucose loading. Acromegaly indications. Failure of surgery to normalize IGF-1 levels. Awaiting the beneficial effects of RT. Unresectable tumors. Drugs. Somatostatin analogues. Dopamine agonists. GH receptor antagonist, pegvisomant. Limitations. Cost. Inability of tumor shrinkage sufficient to relieve any mass effect. Somatostatin analogues. Octreotide, 45 times more potent. Half-life in plasma being 113 minutes. Peak plasma concentrations within 1 hour. Suppress GH levels for 6 to 12 hours. Mechanism of action. Inhibit GH secretion. Partially inhibits GH-induced IGF-1 generation. Simulates IGF-BP1 expression. Reduce GHRH release. Clinical improvement. Headache 84%. Hyperhidrosis 65%. Decrease in ring size and 55%. Improvement in cardiac function and sleep apnea. Octreotide, SC, 100 to 500 mic.GMTs octreotide La. IM, at 28 days interval. Lanreotide. IM, every 7 to 14 days. Pegvisomant. GH reduction. 47%. 56%. 50%. Not useful. IGF-1 reduction. 46%. 66%. 48%. 97%. Frieda-Poo Clinical Review 150 somatostatin analogues in acromegaly.J Endocrinolol Metab 87 to 3013 to 3018, 2002. Dopamine agonists, used both as primary and adjuvant treatment. Bromocriptine up to 20 mg/day. Cabergoline 1 to 2 mg/week. Response rate low. Dopamine agonists, bromocriptine cabergoline GH reduction 20% 44%. IGF-1 reduction 10%. 35%. Frieda-Poo Clinical Review 150 somatostatin analogues in acromegaly.J Endocrinolol Metab 87 to 3013 to 3018, 2002. GH receptor antagonist. Pegvisomant. Check IGF-1 level every 4 to 6 weeks. Monitoring GH not useful. Dose 10 to 40 mg/d. Thiotropic function T3, T4, TSH levels. If TSH levels are normal in the presence of low T3, T4 levels, then TRH reserve is tested. 200 micrograms of TRH is given for, if TSH is elevated to greater than 6 to 20 microunits, ml, normal. Absence of response. Total hypophysectomy. Decreased response. thyroid hormone therapy, glucocorticoid therapy, hypothyroidism, renal failure, depression, thyrotropin-secreting adenomas. Somatostatin analogues, greater than 90% respond. Dopamine agonists bromocriptine, 20% respond. Gondotroph function criteria, absence of other hormonal abnormality. Elevated basal and stimulated responsive gonadotropins. Diabetes insipidus. Polyuria secondary to water diuresis and polydipsia. Due to low levels of ADH. High output of dilute urine. Craving for water, especially ice-cold water. Incidence: 9.2% in microadenoma surgery. 37% in case of total hypophysectomy. Mostly due to extreme sensitivity of hypothalamic neurohypophyseal unit to local alterations in blood flow, edema and traction on pituitary stalk, and is transient. Permanent disturbance of ADH secretion, direct damage to neurohypophyseal unit. Types of presentation: transient polyuria starting 1 to 3 days after surgery and lasting for 1 to 7 days, local edema and traction on pituitary stalk. Triphasic response: polyuria beginning 1 to 2 days after surgery, lasting for 4 to 5 days. Normalization of urine output, SIAD-like water retention 4 to 5 days. Return of polyuria. Transient polyuria beginning immediate post-op. Permanent polyuria beginning immediate post-op and continuing without any interface. Diagnosis: urine output greater than 250 milliliters per hour, greater than 3 milliliters/kg per hour in pediatric patients. Urinary Sg less than 1004. Urinary osmolality less than 200 mg/kg. Normal or above normal serum sodium level. Normal adrenal function. Depends on Pete's clinical status, urine volume, concentration of serum electrolytes, creatinine. If alert, with intact thirst, mild DI. PT can self-regulate water intake. Dipped nasal spray 2.5 micro-GMBD. If thirst mechanism is impaired. Meticulous IO records. Daily weight measurement. Frequent electrolytes, urea, hematocrit. Supplementation of free water. Vasopressin analogues. If consciousness is impaired. Harley IO, urinary specific gravity. -4 Harley electrolytes. Parenteral fluids. Titrated dosages of desmopressin 2,4 microgram 4/SC in 2 divided doses. Chronic DI rare and care of transsphenoidal surgery. Treatment of choice is DIP. Other drugs. Clofibrate 500 mg 2 to 4 times/d. Chlorpropamide 5500 mg/day. Carbamazepine 400-600 mg/day. SIAD less common causes, pre-op medications, anesthetic agents. Surgical stress. Surgical irritation of neurohypophyseal unit. Diagnostic criteria. Hyponatremia. Inappropriately concentrated urine. No renal/adrenal dysfunction. Low serum osmolality. No hypothyroidism. No dehydration/overhydration, water load test. Symptoms of hyponatremia. Acute SIAD, fluid restriction 0.5 to 1.5 liters/day. Treatment. Acute SIAD, fluid restriction 0.5 to 1.5 liters/day. If sodium levels less than 120 mg/L, hypertonic saline plus furosemide diuresis. Correction rate of 0.5 mg per hour. Chronic SIAD. Long-term fluid restriction. Deep glocycline 150 to 300 mg q6 hours. Furosemide 40 mg odd. Lithium. Phenytoin.